Welcome back, everyone, with another session of the USMLE Step 2 CK channel studying sessions. We are on page 338, so Master of the Boards USMLE Step 3, and we are going to start with orthopedic surgery. Last time we did pediatric surgery. I think it went well. We did it in one session, and we hope that the orthopedics is going to be the same. If you would like to open your books, and we can get started right away. I'm going to start with the common adult orthopedic injuries, and we have some general rules about the fractures here. It says here that when you suspect a fracture, let's say a patient has a fracture, we order two views at 90 degrees to one another, and always include the joints above and below the broken bone. So basically, most people will get an AP and lateral view. For example, you can remember that that way you can't really have one view, so two views 90 degrees with another, and we include the joint above and below. All right. The second rule here is to always x-ray other sites in line of the force, of course. So we have an example here, the lumbar spine for someone who falls and lands on the feet. Hips in a patient who has been in a motor vehicle accident with forces of knees against the dashboard. So do not only look at the site where you think the injury is, just look at the line of force that had the patient break his bone. All right. The third one here, it says closed reduction. This closed reduction is the answer for fractures that are not badly displaced or angulated. An open reduction, on the other end, and internal fixation is the answer when the fracture is severely displaced or angulated or cannot be aligned. Of course, open fractures, the bone that are sticking out through the wound, they require cleaning in the OR and reduction within 6 hours from the time of injury. And finally, we always perform cervical spine films in any patient with facial injuries because we would be worried that we can miss it. A side note here, especially with open fractures, is that we can worry about gas gangrene, especially in any deep penetrating or dirty wounds in general. So that's why we have to clean in the OR. 3 days later, we can see the patient to be septic, and he's going to have a tender swollen injury site. And later on, gas crepitus. What we do here, if we find that, is that we treat the patient with a large dose of IV penicillin and hyperbaric oxygen. And this should be able to clear it out. Okay, so we have a question here about in fracture management. It says here that a 27-year-old woman with a known seizure disorder has a grand mal seizure. She complains of left shoulder pain. A PA and lateral x-rays are obtained and fail to reveal a fracture or a dislocation in the left shoulder. She is given ibuprofen for pain. She returned 3 days later with a persistent pain with her left arm held close to her side. She reports that she is unable to move the left arm. What is the next step in management? Okay, so we have here 5 options. First, it says axillary radiograph of the left shoulder, change analgesic to Percocet, CT of the left shoulder, MRI of the left shoulder, and ultrasound of tendon insertion sites. Okay, so my answer would be axillary radiograph of the left shoulder. We want to make sure that maybe the inflammation, the swelling, and so on had not made it able to see the fracture on the first time, or maybe we just missed it, or for whatever reason. So I would do again the axillary radiograph on the left shoulder to have a better view or a different view. So let's see what the answer. Oh, okay. So it says here that the answer is A. And it says, although anterior shoulder dislocation are easily seen on erect posterior, anterior, PA, and lateral films, we look for abduction arms and externally rotated forearms with numerous over-deltoid, like axillary nerve is stretched, posterior shoulder dislocations are commonly missed on these views. So the anterior shoulder dislocations can be seen, and but the posterior cannot be seen that easily. So posterior shoulder dislocation should be suspected in a patient with a recent seizure or electrical burn and shoulder injury or pain. We order an axillary or scapular views of the affected shoulder so we can see the dislocation. All right, this is new to me. All right, so good information here. We have a picture. I can't really see it well, but it's a picture for anterior dislocation of the shoulder. And a side note that says that in anterior dislocation, this is the most common shoulder dislocation, the anterior one. And we look for an arm held closely to the body, but an externally rotated forearm and associated numbness over the deltoid muscle because the axillary nerve is stretched. So this is the anterior one. So anterior one, the shoulder dislocation is common. We look for an arm held close to the body but externally rotated. And the forearm is going to have some numbness because of the deltoid muscle and associated with numbness and over the deltoid muscle because of the axillary nerve stretching. However, in the posterior dislocation, the arm is going to be held close to the body, but the forearm is internally rotated. Okay, that's different. So that's external rotation, that's anterior, and internal rotation, that's posterior. Okay, we have multiple points here in the next page, and it says that those are the best choices for the management of fractures. In general here for surgery, before I continue here, I would advise anybody who has not looked at Kaplan book for surgery, and especially the part for the clinical vignettes, along with the videos if you would like, but you can read it. That's a really good thing to look at. I think it's beneficial. I read it once and I saw the videos, and it's going to help you a lot. You can finish this first and then you can actually look at the clinical vignettes, kind of like a practice, or read the clinical vignettes first and then come back here for a review, whatever you would like. But I think it's beneficial to look at those clinical vignettes and the video if you have some time. All right, so it says here following are the best choices for the management of fractures. So we're going to have a fracture and we're going to see what type of reduction or a type of a sling or operation or whatever as a management for that fracture. So let's get started, and we're gonna divide them into groups just by numbering, and then review them again so we can actually remember together everything. Okay, so first is the clavicle fractures. Okay, a clavicle fracture, easy, figure 8 sling. That's really easy, you don't do anything else. The second is collis fracture. A very famous one. We're going to do a closed reduction and casting. It presents often in an elderly, especially a woman, and who falls on an outstretched hand. We look for a painful wrist with a dinner fork deformity. So here, closed reduction and casting. Collis fracture, closed reduction and casting. Okay, how about we have a direct blow to the ulna, a Montague fracture, or a radius, which is the Galeazzi fracture. I'm not sure if I'm pronouncing those right, but you get the point. Those results in a combination of diaphyseal fracture and a displaced dislocation of the nearby joint. So either ulna or radius here. We do an open reduction here, so it's not closed reduction, and internal fixation. And this is needed for the diaphyseal fracture. And the dislocated joint, we can do a closed reduction. So again, let's review what we have so far. We had a clavicle fracture, which is a figure 8 sling. We have a collis fracture, and we're going to do a closed reduction and casting. We see it in women who are elderly, fall on an outstretched hand. And the ulna and a radius, if they have a direct blow to them, the ulna is a Montague fracture, and the Galeazzi fracture for the radius is going to result in two things. First, a diaphyseal fracture, and then a dislocation of the nearby joint. Open reduction, internal fixation for the diaphyseal fracture, and closed reduction for the dislocated joint. All right? Okay. Great. Now, we have another point that says that fall on an outstretched hand with persistent pain in an anatomical snuff box is a scaphoid fracture. Scaphoid fracture is a special type of fracture, and if you have seen or practiced orthopedics, you know that this causes a problem for physicians to diagnose right away, and you should suspect it in any patient who has an outstretched hand, fall on outstretched hand with a persistent pain and an anatomical snap box. Right away, without even x-rays, it should be suspected as a scaphoid fracture until proven otherwise. Because it takes, and that's why, because it takes 3 weeks to be seen on an x-ray, so you can't really see it right away. Okay, all right, so what do we do to treat that? We place a thumb spica cast to prevent, to help prevent non-union. That's really easy. So it's closed reduction. We're not going to do anything, and the casting. And remember, the thumb is spica cast. Another point here is consider the possibility of hip fracture when in any elderly patient who sustains a fall. So if an elderly patient who falls, hip fracture should be suspected. What do we look for? We look for externally rotated and shortened leg. Okay? Externally rotated and shortened leg. In a femoral neck fracture, they are at high risk of avascular necrosis because we don't have enough blood supply there, and are best treated with the femoral head replacement. So we replace just the femoral head. Okay, so the femoral neck fracture, do replacement of the femoral head. If it's an intertrochanteric fracture, they are treated with open reduction and pinning. So we use pins, and the femoral shaft fractures, they are treated with intermedullary rod fixation, and we should be aware of high risk of fat emboli in femoral shaft fractures. Okay, so a hip fracture here, let's memorize the hip fracture together here. We can have 3 types. This is what the book says here. Either a femoral neck fracture, an intertrochanteric fracture, or a femur fracture, a femur shaft fracture. If we have a femoral neck fracture, this is we suspect that it could have avascular necrosis, and that's when we decide to do a femoral head replacement. That's a safe choice. And the intertrochanteric fracture, we're going to treat it with open reduction and pinning. And the femoral shaft fracture, we're going to treat it with intramedullary rod fixation. Okay, so far we reviewed the clavicle fracture, figure 8 sling, collis fracture, closed reduction and casting, direct blow to the ulnar radius. We do an open reduction and internal fixation for the fracture. And the dislocated joint, we do a closed reduction for it. If we have a fall on the outstretched hand, suspect scaphoid fracture, and what you do is to place a thumb spica cast. Hip fracture, we just said it, 3 types: femoral neck fracture, do a femoral head replacement; intertrochanteric fracture, do an open reduction and pinning; femoral shaft fractures, we do intermedullary rod fixation. I know some people might be annoyed that I'm trying to repeat these things, but if you repeat it with me, if you can, or hear it again and again, and just try to memorize it, that's going to be easy, because we do have a lot of fractures and it can get confusing. So try to put those things into perspective and into your mind by repetition, and spaced repetition, that's going to help. Okay, we have a side note here. That open femoral shaft fractures are an orthopedic emergency. So we talked about the femoral shaft fractures and how we treat it with intramedullary rod fixation, but in open femoral shaft fracture, that's an emergency, and this can result in massive blood loss and high rate of infection. I think it's up to 2 liters, and immediate surgery and cleaning within 6 hours is needed. So that should be done right away. And another thing that to be aware of is the high risk of fat emboli. So 2 things here: fat emboli and the risk of bleeding for femoral shaft fractures, especially the open type. Okay, now we're done with these. Let's get to another point. Another point says here is the trigger finger. A woman who awakens at night, for example, with an acutely flexed finger that snaps when forcibly extended. Okay, so that's the trigger finger here. A woman who awakes at night with an acutely flexed finger that snaps when forcibly extended. And then we have the dequervain tenosynovitis. That's going to be a young mother carrying a baby with a flexed wrist and extended thumb to stabilize the baby's head. it's going to be a steroid injection as the best initial therapy. So the trigger finger and the decurvane tenosynovitis, steroid injection is the best initial therapy. Okay. That's not actually a fracture, so let's just keep that in perspective. Um, Now the next point is the debuterine contractions. This is going to be a contraction of the palm with the palmar facial nodules. The only thing to do is surgery, and if we cannot, if collagenase fails, so that's it. And I think debuterine contractions, you can see it with different things, but liver disease, chronic liver disease, that's a famous one. The next point here is posterior dislocation of the hip. You're going to see a patient who has a history of a head-on car collision where the knees hit the dashboard. This is another orthopedic emergency, by the way. We differentiated from hip fracture by an internally rotated leg. We said in hip fracture, we're going to see an externally rotated and shortened leg. Here, it's internally rotated leg. The leg is also shortened, by the way. So internal rotation, external rotation, that's the difference. What we should do is emergency reduction is needed, and this is to avoid, again, avascular necrosis. So it's kind of like the femoral neck fracture for the avascular necrosis part, okay? Okay, and the next point is going to be knee injuries. Before I go into knee injuries, I just want to remind you of what we did so far. We did the clavicle fracture, the collis fracture, the direct blow to the ulnar radius. We did the scaphoid fracture, the hip fractures, the three types: femoral neck, intertrochanteric, or the femoral shaft. And then we had the trigger finger and the decurvane, the tenosynovitis, the debuterine contractions, and then finally the posterior dislocation of the hip. Okay? Okay. The two emergencies is the posterior dislocation of the hip and the femoral shaft fractures. We should do it in less than 6 hours. And the difference between the posterior dislocation of the hip and the fracture of the hip is the rotation of the leg internally for the posterior dislocation, ironically, and the hip fracture, it's gonna be externally rotated. All right, now let's get to the knee injuries here. The knee injuries, we have first the medial and lateral collateral ligament injury. This is caused by a direct blow to the opposite side of the joint. And what we do here is casting, if isolated ligament injury here. And then what we do later is surgical repair if there are multiple ligament injuries. So multiple ligament injury, it's going to be surgical repair, and isolated single injury, it's going to be casting. All right. I'm sorry. Now, the second type of injury is anterior or posterior cruciate ligament injuries. We're going to see swelling pain in anterior and posterior drawer sign when you kind of pull on the leg and see the knee joint kind of go forward more than it should. That's anterior, and posterior more than it should. That's posterior drawer sign. This is going to be seen in young athletes, and what we do is arthroscopic repair. In older patient, this may be treated with immobilization and rehab, but if you have someone with an athlete, he needs to keep moving, he needs to return to playing sports, you're gonna do the arthroscopic repair. The final knee injury here is meniscal injury. We're gonna see a prolonged pain and swelling with catching and locking during ambulation. There is a special test for it if you have done it before in medical school or something like that, where it kind of like snaps or does have a specific pain when you do that test. So what we do here is to treat it with an arthroscopic repair as well. Sometimes we see people who have the anterior posterior cruciate ligament injuries along with the meniscal injuries. So those can be done together as well. All right. The next point here is the tibial stress injuries. It says here an example is a history of military or cadet marshes we're going to have an x-ray for the patient, and it will be negative initially, actually. So the tibial stress injury, it's not going to show up on the x-ray initially. What we do is to treat it with a cast and order the patient not to bear any weight, and repeat films in 2 weeks to see the injury. All right, so this is a tibial stress injury. We have a side note here that says that Tinel sign has greater specificity than Phelan's sign. And I think this has to do the Tinel and the Phelan sign. I'm not sure where that follows here, but I think this is for carpal tunnel syndrome. I'm not really sure. Well, we're gonna take a look at the carpal tunnel syndrome in a bit, but I think the Tinel sign and the Phelan sign, those for the carpal tunnel, but we'll see. The final one here is the rupture of the Achilles tendon. Rupture of the Achilles tendon here, we're going to see a middle-aged man overdoes it at tennis or basketball, or a patient with a history of fluoroquinolone use. This is really important, actually, fluoroquinolone use, because this can be on the stem, and you should suspect it. And he would be complaining of a sudden popping and limping. What we do is we treat with casting in equinus position, or we can do a surgical repair. Okay? Really easy so far, and I'm not going to repeat the last parts here. They're really easy and very famous. Now let's take a look at wrist injuries. The first one is going to be the carpal tunnel syndrome. Carpal tunnel syndrome is entrapment of the median nerve that causes pain and paresthesias. The most common cause are idiopathic, we don't really know, but sometimes rheumatoid arthritis, acromegaly, and hypothyroidism. Hypothyroidism is important here to consider in any patient who has carpal tunnel syndrome, especially if it's bilateral, and those can predispose to the carpal tunnel syndrome. How are we going to test or diagnose that patient? Well, the best initial test is history and physical. In physical, it says here the Phelan test, so I was correct. It is for the carpal tunnel syndrome, and the Phelan test causes symptoms by flexing the wrist gently and holding the position. So this has less specificity. And then the Tinel sign, which has greater specificity, this causes symptoms by tapping the nerve over the flexor retinaculum and awaiting paresthesias. What are we going to treat that patient with? Well, the best initial therapy is non-steroidals and splinting. If this does not alleviate symptoms, we can have local steroid injections, and this can help in one way or another. And finally, surgical release is recommended when splinting is no longer able to control the patient's symptoms. Okay, so so far we're doing really well, and we have the compartmental syndrome or compartment syndrome next, and it says here that this is the most frequent syndrome when is most frequent in the site of a forearm or lower legs. What we do here is we look for a history of prolonged ischemia followed by reperfusion, or sometimes a crushing injury. And other type of trauma if available, or if we see it. It's going to be pain, and the affected area feels like really tight and tender to palpation. A classic sign would be excruciating pain with the passive extension, but I think this sign, I can't remember the name of that sign, but you shouldn't really do it, and but it happens, excruciating pain with passive extension, and the pulses may be normal at that point. The first step in management is the emergency fasciotomy. So that's a surgical emergency as well. It says here that, as a side note, when a patient complains of pain at the site of a cast, and always, what we do is always remove the cast and examine for compartment syndrome. You do not want the patient to have a compartment syndrome when he is in a cast. Okay? All right. Okay, so now we have the next section is going to be on neurovascular injuries and back pain and so on. We are almost done with it, but we're going to stop. I'm going to stop here for a little while. Take a short break as we are approaching the 25 minutes, and then we can come back and continue together. All right. I hope you you enjoyed that and you are benefiting from it, and I'll see you in a little bit. All right. Bye.